So now that we have seen about the pathophysiology of this disease, let's see the diagnosis and investigations. So since this disease does not have a particular diagnostic test, there's an algorithm that we have to follow, and MRI is the most important investigation that has to be done. So it starts with excluding other structural diseases to and identifying the plaques of demyelination, which again is image based and myelography. Then other sites of involvement are demonstrated through gadolinium enhanced MRI, visual evoked potentials, and other evoked potential where spinal involvement and other involvements are seen. Then inflammatory nature of the lesions are demonstrated by CSF analysis, cell count, and protein electrophoresis. Then other conditions should be excluded by chest X-ray, serum angiotensin converting enzymes, serum vitamin B12, the anti-nuclear antibodies, and antiphospholipid antibodies. So let's see more about these investigations in detail. Uh, so these investigations in multiple sclerosis are important in setting up the different treatment plans. So diagnosis relies on combining clinical findings and investigation results. MRI, which I said is the most important tool, and also the most sensitive for detecting brain and spinal cord lesions. This helps confirm the dissemination after clinical isolated syndromes, and useful for ruling out MS that mimics like small vessel disease and cerebral vasculitis. Now, evoked potential, which include visual, auditory, or somatosensory tests, can detect silent lesions and rarely used now due to MRI's higher sensitivity, especially the gadolinium enhanced MRI. CSF analysis, which mostly shows normal pressure in normal cells, might show lymphocytic pleocytosis during an acute attack, but a very unique oligoclonal Ig bands found in 70 to 90% of the patients in between the attacks are seen. These bands indicate intrathecal inflammation but are not very specific to MS. Now, fundus examination may be done because of the symptoms that could indicate so, but it is usually found out to be normal. Now, to rule out other conditions like infections, vitamin B12 deficiency, and spinal cord compression, different tests and history particular to these symptoms should be taken. Diagnostic criteria is two or more attacks with either objective clinical evidence of at least two lesions or objective clinical evidence of one attack with reasonable evidence on clinical history or at least one prior attack is diagnostic of MS. And let's see how the lesions look. So you can see that here the demyelinating lesion is present in the cervical spinal cord, and this could indicate MS. You'll see more lesions like this. So it's a sagittal T2 weighted fluid attenuated inversion recovery or FLAIR image in which high signal of cerebrospinal fluid has been suppressed. CSF appears dark, whereas the areas of the brain edema or demyelinating appears higher in signal as shown in here in the corpus callosum. The lesion in the anterior corpus callosums are frequent in MS and are rare in vascular diseases. Now, these lesions are frequently oriented perpendicular to the ventricular surface, corresponding to the pathological feature of perivenous demyelination or Dawson's finger. Now, in the other image here, we see these spots, which are spots of blood-brain barrier disruptions identified by gadolinium DTPA with as high signal intensity regions. Uh, in spinal cord, T2 sagittal, the fusiform high signal intensity lesion is seen, which is a plaque, as seen in the other image before. Now, let's see the treatment options. So, for a acute episode treatment, a high dose glucocorticoids with methylprednisolone is given IV or oral for 3 to 5 days. Uh, these usually help in shortening the acute exacerbation. Long term glucocorticoids is avoided because they have severe side effects. Then, glucocorticoids can be used up to 3 times a year for severe disabling episodes. Osteoporosis prevention should be kept in mind before considering these cases. Then, disease modifying treatments are most important, where DMTs like beta interferons and galantamine acetate have reduced relapse rates and MRI lesions. Do not treat early or preclinical MS and have specific licensing and safety requirements. Now, management of symptoms and complications. So, this disease presents with a plethora of symptoms, and thus will include a lot of different interventions by different professionals. Physiotherapy, occupational therapy, home aids are very important. Then, bladder dysfunction requires medications, catheterizations. Sexual dysfunctions can be treated with medications and counseling. Then, multidisciplinary care team becomes very important, and patient education is very vital. Now, disability management. Support for the patients and families is essential. Specialists of MS nurses and multidisciplinary team plays a key role in long-term care. Pregnancy does not worsen MS, but relapses may increase after childbirth is one of the important facts to remember. Now let's see about the DMTs in more detail. So interferon beta is an injectable form which acts by modulating immune response and reducing T cell activation and inflammatory cytokines. It is used in the relapsing remitting type of MS, where common side effects include flu like symptoms, injection site reactions, and increased liver enzymes, maybe depression. Then glatiramer acetate, which is also an injectable DMT, mimics myelin protein and shifts T cell response from Th1 to Th2, which is anti-inflammatory. It is again used in relapsing remitting MS. Injection site pain, chest tightness, and flushing, lipoatrophy may be the common side effects. Triflunomide, which is an oral DMT, inhibits pyrimidine synthesis, thus decreasing the T and B cells proliferation. Again used in relapsing remitting MS. Hepatotoxicity, teratogenicity, hair thinning, and GI upset are common side effects. Diethyl fumarate, which is oral DMT, activates NRF2 pathway, which causes antioxidant and anti-inflammatory effects. Used again in relapsing remitting MS. Then flushing, GI upset, lymphopenia, and an increased risk of progressive multifocal leukoencephalopathy. Fingolimod, which is again oral DMT, is SIB receptor modulator, which causes sequestration of lymphocytes in lymph nodes, and is used in relapsing remitting MS. Can cause bradycardia, macular edema, increased liver function tests, infection risk, and PML. Alemtuzumab, which is an IV infusion DMT, is acts by monoclonal antibodies and targets CD52 on lymphocytes, thus depleting both B and T cells, which is most commonly used in active RRMS, which can cause autoimmune disease risks like thyroid and ITP, and infections and infusion reactions. Natalizumab, which is a very important drug, DMT drug, which is used as IV infusion. Uh, the monoclonal antibody blocks the alpha 4 integrins, which prevents the immune cells from crossing the blood brain barrier. It is used in highly active RRMS. This virus, called John Cunningham virus, is present in some people and is a common virus found in them naturally. So, if these patients are treated with natalizumab, they have a higher risk of developing PML, though other side effects like hypersensitivity, liver toxicity could also be there. Now, mitoxantrone, which is an IV chemotherapy, suppresses immune function via DNA intercalation and topoisomerase inhibition, is used in progressive MS and can cause side effects like cardiotoxicity, leukemia risk, amenorrhea, nausea. That's rarely used because of its toxicity. Now we move on to treatment complications to in MS. So common complications like spasticity could be treated with physiotherapy. Then drugs like baclofen, dantrolene, gabapentin, Sativex could be used. Tizanidine, intrathecal baclofen, and local IM injections of botulinum toxin could be used. Then chemical neurectomy in very severe cases, if it's not getting correct, can be done. Now, dysesthesias can be treated by carbamazepine, gabapentin, phenytoin, amitriptyline. Bladder symptoms, as already discussed, could be with drugs, treated with drugs. Fatigue with amantadine, modafinil, amitriptyline, and erectile dysfunction can be treated with sildenafil and tadalafils. So, MS in pregnancy. MS in pregnancy requires counseling and modification of drugs. Though the relapse rate during pregnancy reduces due to hormone mediated immune modulation, uh, disease modifying drugs, which could be teratogenic, should be stopped 6 to 8 weeks before conception and restarted after breastfeeding ends. Postpartum relapses peaks in the first year after delivery due to immune system rebound. Let's Let us just look at the important pointers that we saw in MS. So, specificity of pathogenic T cells is to protein antigens in myelin, which are myelin basic proteins. Then, the principal mechanism of tissue injury is the inflammation mediated by Th1 and Th17 cytokines, which cause myelin destruction by activated macrophages. Then, clinicopathologic manifestations include demyelination of the CNS with inflammation, paralysis, uh, optic neuritis being a very common symptom. Other important points like the drug modifying factors with the beta interferons and natalizumab used in treatment, and MRI, which is gadolinium enhanced, is very important. So, this sums up the topic of MS. Feel free to ask any doubts, and thanks for watching.